And we're live. All right. I'm John Reagan, Dr. John Reagan, I guess. I'm one of the interns over at Freeman ER. And today we're talking about adult cardiac arrest. So a little bit about today. I can tell you about me a little bit. Then we're going to go over some fun statistics about this, some of the physiology that happens during adult cardiac arrest, and talk about what the initial response to that looks like. Then we're going to run through our beloved ACLS algorithm a little bit, talk about some of the diagnostic workup, and then talk a little bit about, okay, you got them back, now what, after postcode, and then touch briefly on termination of care. So, who am I? I'm one of the interns at Freeman, like I said. I was born in the KC, Missouri area, so have to put a chief something up there. I moved down here to Joplin in 2020, right as COVID started, start med school. And then as far as medical background, I'm sure some of you have seen me try and put in an IV and you say, yep, he's got no background at all. And you're correct. So both my parents are in the insurance business. And so med school is my first exposure to the medical side of things. So let's talk about numbers a little bit. You'll see that if you do the math on some of these, they don't add up to exactly 100%, might be 99 something, 98 something. That's by design on my part, because we all like big round numbers and it's easier to remember. So adult cardiac arrest in the United States, there's a little more than 500,000 cases per year. As far as out of hospital versus in hospital, it's about the same. A little bit more in the hospital because we got all the sick people. So you guys are probably more interested in the out of hospital, and the numbers there are kind of interesting. 70% of them happen at home or the residence that the patient lives in. That kind of TV scene of, somebody crashing in public and then someone gets to start CPR and, crack them in the field and all that fun stuff, that rarely happens. It only happens about 15% of the time. Then the remaining 15% happens in a nursing home or another care facility. I'm interested to see the numbers around here because I feel like that's a little different. Half of these arrests are completely unwitnessed. They are found down, which I think probably contributes to how brutal the statistics are as far as survival goes. A third of them are witnessed by a civilian. Usually it's a family member or a close friend. And then that remaining 15-ish% is witnessed by a first responder, whether it's paramedic, EMT, or fire department, police department, something like that. Your average cardiac arrest patient is going to be a 65-year-old male presenting with PEA. The two most common reasons for that arrest are either cardiac pathology or respiratory pathology. We'll get into this a little bit later, but cardiac pathology, they typically present with VFib or VTAC, so I find it kind of interesting that PEA is the most common. They didn't really give any reason for that. So survival to discharge. As far as in-hospital arrests, with all of the wonders of modern medicine and being on the cusp of gene editing, still only 1 out of 4 will walk out of that hospital or get wheeled out. So that's pretty surprising that, with all the gadgets we have, we still aren't really able to get them back from the dead. As far as out of hospital arrests, the one you guys bring to us, only 10% survive. And if a bystander starts CPR, whether it's somebody, a member of the care team or one of you guys start CPR, it doubles the rate of survival from 7% to a whopping 13%. So still pretty abysmal. Kind of averages out to about 10%. And Midwest is best. Apparently, we have some of the best cardiac arrest survival rates in the nation. So go us. The Midwest and the South have the highest regions compared with the Northeast and the West Coast. So good job, everybody. The survival rate for cardiac arrest drops 10% per minute of delay of starting first aid, whether it's CPR or the use of a defibrillator. And I think that's probably one of the reasons why the survival rate is so low, like we talked about. Half of these are unwitnessed, so the delay between the start of the arrest and actual start of care is probably pretty prolonged. For the lucky few that survive, most of them will have long-term psych issues. I mean, you did die and come back, so it's pretty traumatizing. Most of them have PTSD, anxiety, depression, things like that. Then a large percentage of them have long-term neurological or cognitive deficits. Most of the Their entire brain was mildly, moderately, or severely infarcted for an extended period in time. So it tends to do some damage. And half of the survivors tend to have a decreased ability to do the activities of daily life. So even if you do make it out, you're not making it out with some battle scars. Talk about physiology. If you ever went to, did some biochem, you got your Krebs cycle. We're not talking about that, thankfully. So rhythms in cardiac arrest is usually broken up into two different categories. Those categories are shockable and non-shockable. Each of those gets 2 rhythms apiece. Your shockable rhythms are VFib and VTAC. AFib is probably the easiest way to describe VFib. AFib, your atrium will flutter, and therefore it's not able to properly contract and push that blood down to the ventricle. Same thing happens in VFib, except that ventricle is now not able to push blood out to the rest of your body. So you have a really terrible cardiac output. VTAC is similar, but instead of fibrillation, the heart rate is just so high down in the ventricles that the ventricles are not able to fully relax and refill with blood. So they are still pushing blood out, but just not enough to cause any actual perfusion. Then our non-shockable rhythms, PEA and asystole. PEA is most common presentation, and that's where the heart is still working, technically. Still getting electrical activity, you still are getting some mild contraction of both the atrium and the ventricles, but it's not enough to generate any meaningful blood pressure and generate a pulse. And then there's asystole, which is no signal at all. Given enough time, the VFib, VTAC, PEA will eventually progress to asystole. Moving on, we got our H's and T's, and Dr. Ahmed's going to talk about this in another lecture, so I won't go into too much detail. But whenever you're talking about cardiac arrest, while you're trying to get him back, you're thinking about reversible causes. You got 5 H's. They tried with acidosis, try to make that an H, and then their T's. You got your tamponade toxins, tension pneumo, and then your thrombosis, whether that's a lung or the heart. We'll talk about those in a little bit more detail a little bit later. There we go. So your initial response, you see your person, you get on scene, find your patient, and what do? So what do they typically look like? Well, they kind of look like this guy, kind of look a lot like a mannequin, completely unresponsive, generally pulseless. And literature is a little bit mixed on this. Apparently, they might have some signs of breathing, whether that's agonal or just very shallow, rapid. But 9 times out of 10, they're not breathing at all. And since I compared our cardiac arrest patients to a mannequin, I should say don't do the office thing and Silence of the Lambs then. Now, scene safety. I'm going to sound like the OSHA guy for a little bit. Telling you to do your stretches and all that before you go out. But scene safety is a big thing. It's kind of one of the first things you do when you're seeing a cardiac arrest patient. Sure, we've all taken calls where you're being staged for police department, SWAT, fire department, something like that. And whether that's just due to a domestic thing or an actual like shooter or something like that, things might be able to get hairy pretty quick. Animals, people got dogs, and sometimes dogs aren't nice. They can pose a threat, and in this part of the country, people have cattle, horses, whatever. Then fire. You guys bring a lot of patients from burning buildings to us, and you're not going to code somebody in the middle of a fire. It's fire department's job. Drag them out to you, and you guys do your thing. In that same note, unstable structure, whether it's after a fire or an explosion or a natural disaster, if that structure is not stable enough for you to safely code that patient, don't do it there. Get them somewhere safe and then do it. Protect yourself so you can go protect more people. Down power line, I think of that really old G.I. Joe public service announcement where they're talking about don't touch down power line. So after big storms or what have you, be careful. Carbon monoxide exposure. We get some people who decide to hook up, their car in their garage and try and off themselves that way. Carbon monoxide exposure is, how it does kill them, and that can actually pose danger to you guys. If you don't let that garage air out and decide to charge in and try and coat them in the garage, you can expose yourself too. Hazmat. So whether we're talking about industrial chemicals like at a 3M plant up in Nevada, or fertilizers, insecticides, things like that, or drugs, if you're a bit more city folk and you're dealing with a lot more fentanyl up there than you are down here. We've all heard cases of first responders overdosing because their patients covered in bad materials. And last but not least, other people. People suck, and they try and keep us from doing our job. Whether it's the patient, in this case not, because it's cardiac arrest, but whether it's a family member or a significant other or a friend or whatever, sometimes they get in the way and sometimes they get threatening. So moving on. Chest compressions. I'm sure nobody's done these before, but we're going to talk about them a little bit. They are the most important part of coding a patient. It used to be, if you're a sole provider, do your chest compressions and your rescue breaths, but now that's been shown that just keep doing chest compressions until someone's able to help you out. Going over some of the basics here. Hand placement, hand over hand, right in the middle of the sternum. If you can, look like this lady here and get your shoulders over your hands. Helps distribute that force better, but you guys are in the back of a moving vehicle. I get it. It's hard. The rate, you do 100 to 120 beats per minute. If you compare that to a normal patient, it is tachycardic, but we'll talk about why. Everybody's got their own song, whether it's the Bee Gees or Queen or Pink Pony Club, if you're my generation, to try and keep you on track. Compression, you're compressing at least 2 inches. It's kind of hard to evaluate, when you're over somebody, but after you do it, a bunch of times, you kind of get used to it. Now we have feedback devices on the Zoll or what have you, where it can actually tell you if you're not compressing enough. So that's really great. And then allowing full chest recoil. This is the, probably one of the most common things you run into when you're new at chest compressions. You're so, amped up and excited to be coding this patient that you're just slamming on their chest and not allowing full recoil. It's going to decrease the cardiac output, not allow their heart to refill with blood, and it's pretty worse overall for the patient. Now, if you're lucky enough to have 2 people, the official rate is 30 compressions to 2 rescue breaths. If you do the math out on that, it gives you a respiratory rate of about 10 to 12 per minute. Now, that's a little bit kind of on the lower end if you compare that to a normal person, kind of mid-teens usually, but that is enough to give enough oxygenation and ventilation, most importantly, to give them enough oxygen to keep working. Now, mouth-to-mouth has kind of gone on by the wayside. No one expects you to kind of sandblot it and do that anymore. But like I said, they've also found that chest compressions is best if you're working by yourself. So don't stop chest compressions to do rescue breaths. So CPR, it's the best life-saving technique that we have to recreate what the heart and lungs do. And good CPR, I'm putting that in quotes. We'll talk about that in a bit. Best case scenario only recreates 25% of what the heart's capable of putting out on a normal basis. So best case scenario, they're still hypoxic. They're still not breathing off what they need to. So, but still, CPR, we all do a good job of it. We all do it all the time. So we're good, right? But not quite. The journal JAMA did a study. They did a couple studies. They're kind of on the smaller end, but still kind of eye-opening about the quality of CPR during a code. Now, they looked at what they call no flow time, which this is after you count for your rhythm checks, your pulse checks, charging, rhythm analysis for a defibrillator, actually shocking the patient. What they call no flow time is the time when you should be doing compressions and you're not. So inappropriately not doing compressions. So they found that for in-hospital arrests, that no flow time is 25% of the total code. And I think that's pretty crazy. So a quarter of your code when you should be giving chest compressions is not getting chest compressions. For the pre-hospital folks, it's even worse. It's 40%. It was like 35 to 40%. And, that's no judgment on EMS. I know you guys are busy. You're usually a little undermanned, understaffed. and you're in the back of a moving vehicle, so you're kind of preoccupied. But at least we're giving good compressions, right? Well, no. In hospital, 30 to 40% of them are bad chest compressions, whether it's too slow, too fast, not deep enough, or not allowing recoil. So all the professionals in the hospital that do this for a living, quarter of the time they're not doing them enough, and 30 to 40% of the ones that they do aren't good at all. Out of hospital, again, a little bit worse, 60 to 70% are bad compressions. Again, whether it's improper rate, improper depth, improper recoil, what have you. So we aren't doing enough chest compressions overall, and when we are, they aren't good ones. So again, like I said, these are just studies. Studies have issues, whether it's the sample size, the level of training at the place they studied, the location, all that. But it is kind of eye-opening to see that the professionals, people who get paid to do this for a living, tend to have pretty bad CPR. So is this a training issue? No, it's not a skill issue. We do it all the time. We're good at it. So I think what it's saying is that people are human. It's a very precise movement that we're supposed to use our entire body to do over and over and over again at a rapid rate while we're busy doing other things. American Heart Association, I'm sure you saw, put out a statement about a week or so ago about mechanical CPR, thumpers, geezer squeezers, whatever you want to call them. And they said, we don't recommend them to be routinely used because there's no difference in the ROSC rate, neurological outcome, or overall survival to discharge when they compare it to high quality CPR. Like we just talked about, we don't do high quality CPR because we're human beings. So in theory, thumpers should decrease the no flow time because it's a simple on off switch. Turn it off when you got to do your rhythm check and all that, and you turn it right back on. Thumpers don't get tired, and thumpers are more consistent than we are. They don't have to get switched out every 2 minutes or whenever we get tired. Now, we should all know how to do CPR, just like, now we have the glide scopes to innovate, but we all should know how to do direct. But especially in environments when manpower is low, like y'all, mechanical CPR devices are kind of a miracle. My opinion, give it 5-10 years, I think they'll be everywhere. So rescue breaths. Going to go over some of the basics here. Patient positioning, you got your sniff position. I don't know who sniffs in that position, but that's what they call it. The one person technique, you got your bag in one hand and then your mask in the other. You got your CE shape, C clamps around the mask where the tube comes out, and then your E kind of cups underneath the jaw. Kind of provide a little bit of a jaw thrust, trying to open up that airway. I'm just going to talk about BVM here because it's the standard. If they're on a ventilator, then that's your own thing. In CPR, we use 100% FiO2. We're not messing around with titration when they're dead. So they recommend one breath every 5 to 6 seconds. So like we talked about, mathing that out, it's respiratory rate about 10 to 12. Now, if you're coding somebody, hopefully your patient's on their back. If not, something bad's happened. And if we talk about CE technique, but if you have a 2-person technique, whether it's just difficult, to properly bag them, or you're just, got a few extra people, a student or something, one person's manning the bag, and then the other is either doing the CE technique with both hands or what they call 2 thumbs down. Basically put a thumb on each side of where that tube comes out, use the rest of the fingers to curl around the jaw and just press that mask right into their face. Volumes. So officially they say enough volume is appropriate when you can see chest rise. But I don't know how well you guys can see chest rise when you're doing chest compressions. You want me to stop or keep going? Okay. We'll pause for a bit. All right. I get to use my South Park beam again. Your laptop on the internet? No, I'm not doing anything at all. All right, I can go back and slow down a little bit. My live chat is
keeping up. And I just posted that we're working on it.
It's weird that the lights are recording. Those had trouble with that before. I've been deleting them because we don't need them. Okay. This one. Okay. Well then let's continue.
You want me to start back up that CPR slide or where I'm at? Okay.
Recording all this, everything we're saying the last 2 minutes too. No, you're good. Just keep going.
So rescue breaths, we talked about positioning, 1-person, 2-person technique. We're on to volume now. So like I said, I don't know how well you can see chest rise on a patient getting compressions. So let's do a little fun math here. An ambu bag holds 1.5 liters worth of air, 1,500 mils. Now tidal volume is calculated to be 6 to 8 mils per kilogram of ideal body weight. Now around here and most everywhere else in America, we don't have ideal body weight, but ideal body weight for male and female averages out 80-ish kilos, and 600 mils for tidal volume falls nicely right in between that male and female range. How convenient, a one-handed squeeze of an ambu bag delivers about 600 mils. So one-handed squeeze is typically sufficient to give a good tidal volume. Now you got your really big people where they need a little bit larger tidal volume because they're a large human being. Two-handed squeeze will give you about 1 liter. Now some troubleshooting, because things happen and some things break when you don't want them to. First thing, just doing a quick equipment check. Is the bag connected to the mask? Is the mask have a leak? Is the O2 turned on? Is it hooked up to the O2? If you're having trouble bagging them, consider a 2-person technique if you have the manpower, especially seeing if a patient's got a big old beard. You could consider an advanced airway, and that's follow your guys' protocols, whether it's LMAI gel, intubating them, or if you guys really want to meet a lawyer, you can crack them in the field. Again, talk to your supervisor about what your guys' protocol is. Obviously, if they're tubed, you can use a ventilator, which frees up another person to continue doing other stuff. Funny enough, nobody says that you don't need a ventilator because high quality bagging is just as good. So that's my last soapbox about AHA. Defibrillation, everybody loves Edison medicine. It gives you a taste of the dark side. And talking about defibrillation, it's only used on shockable rhythms, which we talked about are VFib and VTAC. They've found that early defibrillation has been shown to have one of the greatest impacts on survival. And that's why the huge PR campaign of having AEDs everywhere has been helping. Again, I'm sure you guys have never used one of these before, so let's talk about how to use one real quick. Found this awesome diagram talking about pad placement. Probably off the manufacturer website or whatever. But your right pad goes lateral to the sternum, underneath the clavicle, somewhere in that chest area above the nipple. Left pad goes below the left nipple, or wherever the equivalent is. If you got a female with a different breast size, it goes below the left nipple, mid-axillary line. So line up the middle of the pad with the middle of that axilla. There's your spot. Now, if you're using a civilian AED, it'll do all the math for you on what the energy setting is, and they're convenient, so that way a layperson can use them. Now, the ones that we have in the trucks and at the hospital, you do it yourself. So we're trained to. Set it to that defibrillator setting. If it's not working, it might be on pacer, might be off, might not be plugged in. But set it to defib, let it analyze that rhythm, and then if it says to shock, charge it and shock them. In the meantime, while it's charging, start CPR again. Like we talked about, our no-flow time is pretty darn high, even with us professionals. So do that until it says shock. Then clear, everybody clear, touch, click that button and it'll shock them. Guidelines say the energy delivered is somewhere between 120 and 200 joules. That's on these modern biphasic defibrillators. There's some really old monophasic defibrillators, which I believe the energy level is like 300 or 360. Some common issues people run into, bad placement of the pads, whether it's in the wrong spot or pads are broken, wet skin, preferably needs to be dry. We got some hairy people out here, so they actually do recommend having a little impromptu waxing session with the first set of pads, and then using the second set of pads to actually deliver the shock. And apparently some kits actually have a razor or trimmer. I don't think you guys are doing that in an ambulance. So moving on from there, here we go again, ACLS. Starting off with its younger cousin, BLS. Do your good BLS stuff, your good CPR, your good bagging and whatnot. But what ACLS adds on is the medicine side of it. Do a pulse check and a rhythm check every 2 minutes. If it's shockable, shock them. If not, go back to CPR. While this is happening, get your IV access. I mean, you guys are awesome at shoving 18 gauges into toes and somehow getting, flush on that. I don't know how you do that, but so I'm not going to lecture you on that. But if all else fails, you got the drill. Technically, the humeral head is the best spot to put an IO because of how close it is to the heart, but, get what you can. Beginning of our pharmaceutical journey starts with epi, 1 mg every 3 to 5 minutes. Now, I don't know who's erring on the 5-minute side instead of 3, but that's just the range they give. I also know of some people who do it every 2 minutes because that lines up with your pulse checks and it's convenient. But when talking about ACLS, I'm giving you the official recommendations. You're going to see some people do some different things. It's neither here nor there. You do you. Come on. Refractory VFib and VTAC. Okay, you shocked your guy twice, and they're still in that shockable rhythm. Now what? You got your antiarrhythmics. ACLS tells us that amiodarone and lidocaine are our options. Personally, I feel like most people use amiodarone because the dosing is standardized. It's the same for everybody. Lidocaine is weight-based, so it's a little different. But you'll see here, officially, it's for shockable rhythms, not responsive to shocks. So you shocked them at least twice. It's not officially used for PEA or asystole. However, I'm sure you guys have all seen or been part of a code where they're given AMI because they're not getting any deader. So amiodarone, first dose 300 mg, 150 for the second one. It's easy. It's the same thing for everybody. If you decide to do lidocaine, it's 1 to 1.5 mg per kg on the first dose, and then half of that for the second dose. So here's some quick math. Not a ton of people weigh 70 keys out here, but there's your math for a 70 kilo and 100 kilo patient. Now, lidocaine gives us a range, 1 to 1.5 and 0.5 to 0.75. Which one do you use? I don't know. It's up to you guys. And they don't give any recommendations of which end of the spectrum to use. Some people of the school thought of it's easier to give more drugs and take away. And some people are of the idea that, I'm not going to mess around with baby doses here. I'm just going to send it. So again, leave it up to your judgment. While all that's going on, assess the cause of the arrest. Now, I will say most of you guys aren't going to have that cause figured out by the time you get to us. But statistically, it's either heart attack or acute respiratory failure. However, we talked about our H's and T's, so let's go over it one more time. But first and foremost, get them to the hospital. We have more people, more drugs, and ORs, which are great. So sorry, Dr. Ahmed, I'm stepping on your toes, but we won't go too in the weeds with our H's and T's. So there's that. Already talked about time frame. You guys probably won't figure it out by the time you get to us, and that's fine. Hypoxia is our first one. Technically, multiple things cause this, but 9 times out of 10, it's an airway thing. You do, there's a foreign body, remove it if you can. There's secretions or blood or whatever, suction it out. Best way to help is an advanced airway if you're able to get it. Like I said earlier, follow your own protocols, but make sure that you're bagging effectively. That is the biggest thing that you can do to help. Make sure you're delivering enough oxygen and breathing off that excess CO2. End-tidal CO2, we'll talk about that in a little bit, is a very good measure of how good your CPR is. Like I said, we'll talk about that more in a bit. Hypovolemia, they don't have enough fluid in their body to support their circulatory volume. Most obvious one is massive hemorrhage. All your preceptors in med school and residency are going to beat it into you of, they're not bleeding spaghetti water, so don't give them saline, give them blood. However, you guys don't have blood. Some places are trialing, having blood products on trucks, and they're trialing actually dehydrated plasma that can be reconstituted in sterile water. I think that's super cool. Hopefully we get that soon. But in the meantime, IV fluids are a great temporizing measure. In the same thought, keep them from losing more volume, stop the bleed. You guys know how to do this. It's direct pressure. If you have to tourniquet the limb, you have to pack the junctions, all that stuff. Dehydration is also a big cause. We won't see this as much around this time of year, but in the summer, you get those people who pass out in the park, and they're severely hypovolemic. In that case, you just replace the volume. You also see this a lot in burn patients because they lose a lot of fluid, one, from the heat, and then also the fact that a lot of their skin's burned away, and so they lose a lot of fluid through that. And lastly, pressors. For your people in like septic shock and things like that, can be a big help, but hemorrhagic shock, big no-no. You'll increase the bleed. Otherwise, if you guys have Levo or Neo, whatever it is on your guys' trucks, you guys can use that at your discretion. Acidosis. They did their best on making this an H with their hydrogen ion. But one of the best things you can do is just good CPR. We're not going to be fixing their pH balance in their kidneys and whatnot. Probably not even in the ER. But do your best you can with those rescue breaths, because that will breathe off that carbon dioxide, which will help prevent this acidosis from getting worse. That being said, don't hyperventilate them. Because weirdly enough, this causes the coronary arteries to get hypoperfused, which will decrease what little cardiac function they have left. So I don't think we want that. Bicarb. If you guys have met Dr. Iraqi somewhere, he just kind of shivered a little bit because he's done a lot of research on bicarb, and he's not a fan, understandably. Most of the time, it's no. It hasn't been shown to help at all. In fact, it's even been shown sometimes to worsen outcomes. However, there are some instances where giving bicarb is useful. TCAs. Not a ton of people on TCAs anymore, but you still get a good amount of them on it. They decide to take a bunch of them. The antidote's bicarb, or at least that's the temporizing measure until they metabolize out all those TCAs. Hyperkalemia. If they have severe hyperkalemia, that bicarb will help. And then severe acidosis, aka pH under 6.9, when they're in DKA, has been shown to help. Otherwise, technically, you're not supposed to give it. And like I said, do your own thing. They're already dead. And then, weirdly enough, vasopressors. If the pH is under 7.1, getting back into some chemistry here, vasopressors don't work well. So if you got a person who's severely acidotic and you're giving them pressors and not responding, giving them some bicarb will probably help get their pressure back up a little bit. Again, we use that in the ICU more often, not as much during codes, but like I said, use your judgment. Hypothermia. I had a guy tell me, it's a well-known statement online, nobody's dead until they're warm and dead. Again, you guys are busy doing other stuff on your trucks, but if you have time, I know you guys have blankets and heat packs. That's kind of, I'm not sure if that's the extent that you guys have on yours. We got warmed IV fluids and bear huggers. Again, we have more fun tools. But if you can help start the warming process on the way, great. Obviously, don't burn your patient, but do the best you can. But more so just some fun tidbits. Calcium gluconate helps prevent arrhythmias. We've all been taught that it stabilizes the cardiac membrane. I'm going to put that in quotes. I'll talk about why, and it will prevent the arrhythmia. They did some more studies of it, talking about why this actually works, and they found out that it doesn't work like that at all. It increases the electrical velocity of conduction through the heart through L-type calcium channels. I don't care. It's not going to change anything we do, but it is fun to know, especially if you're on the internal medicine side. So we give 1 gram of calcium gluconate, and that buys us about an hour of time, which hopefully, unless you're out in the sticks, should be long enough to get them to us. Maybe you guys have had some transports up to KC or Barnes Jewish or something like that, where you've had to give a few doses of that, but as far as getting a cardiac arrest to us, that should be good. Insulin. Again, official guidelines, 5 units IV, not sub-Q, followed by 1 to 2 amps of D50. There's a big asterisk with the whole D50 thing, because again, some places don't have it. And if your patient's super hyperglycemic, don't worsen it. But the reason why insulin makes your blood sugar go down also causes potassium to go into the cells. So it will temporarily decrease the amount of potassium in the bloodstream. So there are some recommendations. If their blood glucose is above 250, don't give them anything. There's some of like you can give half a dose if they're between 180 and 250. But moral of the story is if their blood sugar is normal to a little high, give them some sugar. And if it's super high, don't. And again, this will last about 4 hours, which should be enough to get you guys to us. Albuterol, we do this in the department sometimes. It does cause a temporary shift of potassium into the cells. I don't know how feasible it is for you guys to, give somebody albuterol while you're bagging them or ventilating them all the way here. But if you have that option, it does work. It's doable. And again, there's a few more options you have, but they're the options we have at the hospital. Emergency dialysis, Localma, think Kxalate if you're a little old-fashioned, things like that. Opposite end of the spectrum, hypokalemia. Do you guys have point-of-care electrolyte stuff in the truck? I imagine not, and most people don't. Big moral of the story is if you got somebody with massive fluid loss, whether it's vomiting, diarrhea, things like that, electrolytes probably pretty low. But if you start to see that, those EKG changes that make you think, our potassium's a little low. Moral of the story is they're going to need a lot of potassium, more than you can probably give on the way. Their potassium's 3, which normal is 3.5 to 5.5. They're going to need somewhere between 100 and 200 milliequivalents, which is a lot. And if their potassium is 2, they're going to need 400 to 600. So again, it's more than you guys can give and more than we'll probably give in the emergency department. The one that everybody uses is potassium chloride. Some places have potassium acetate, but it's pretty rare. But potassium chloride, the caveat with that is that it can worsen acidosis. So you kind of have to keep that in mind, kind of balance risk and benefits of if you have an acidotic patient with hypokalemia. So potassium cannot just be slammed into an IV like epi or whatever can, and that's actually how we do the lethal injection. Slam a bunch of potassium, causes an arrhythmia, and that's part of the reason why they die. The replacement rate in like a normal, non-emergent but low patient is 10 to 20 milliequivalents per hour. That's a lot lower than our required for somebody. Typically it's 10, but if you got a central line and you're watching them close, you can go as high as 20. The replacement rate during adult cardiac arrest is 20 milliequivalents over 2 to 3 minutes, which is way quicker. It's also recommended to follow with 2 grams of IV mag, which again, I don't know if you guys have that. It will help prevent them from losing additional potassium through their urine. I don't particularly care about how they're peeing if they're, in cardiac arrest, but it will help decrease the risk of torsades. So, get a little benefit right there. Tamponade. Only definitive treatment of that is pericardiocentesis. So, if you guys decide to do that in the field, good on you, but I don't even like the idea of doing it in the department. So, big moral of the story there, get them to the hospital as soon as you can. If you got a patient who you're suspecting tamponade, because I don't think you guys have ultrasound on your trucks, yeah. But if you have a patient who you think having a tamponade with and their volume depleted, has been shown that you can actually give them a small bolus of IV fluids. It'll help replenish that intracardiac volume and help kind of push against the pressure of the tamponade. Toxins. It's really just specific to whatever it is. If it's a tricyclic overdose, like we talked about, you can give bicarb. If it's like an insecticide or a fertilizer, you can give them atropine. If you have carbon monoxide poisoning, you give them 100% O2, but should be doing that already, thankfully. Yeah, weirdly enough, they do say Narcan, the dead person. It won't stop or reverse the arrest, but it can help remove some of that central nervous system depression and potentially, hasn't been fully proven yet, increase your chance of ROSC. Another aside, the one thing that they talked about over and over again was regardless of whatever they overdosed on, if they seize, give them benzos. Now, a big thing with toxins also, wear your PPE like we talked about, scene safety, whatever mask or gloves or gown you have to use, keep yourself safe. And then decon, if you guys have to strip them in the field, you can. We have a decon shower here, and when you guys bring a trauma patient to us, we strip them anyway. So just be safe there. Tension pneumo, most TV-worthy one, secondary only to a cardiac tamponade. Big thing with this is if they have a sucking chest wound, whether it's from a gunshot or whatever, got 3-sided occlusive dressing. Some places have like legit trauma chest seals. If you have those, awesome. But the most common temporizing measure, not definitive, treatment of a tension pneumo is a needle D. We're all taught second intercostal space, mid-clavicular line on whichever side the pneumo is. However, this is where some interesting things come up. In the emergency department, sometimes we forego this and just either do a finger thoracostomy or just throw a chest tube in. Depends on how emergent this is. We'll talk a little bit more about chest tubes in a bit. But they have done some studies and finding that this location, second intercostal space, mid-clavicular line, isn't working as well as we'd hoped over time. Now, maybe this is because Americans are getting more buff, or I think it's a little more fluff than that. But regardless, there's too much tissue between the skin and the pleural space for it to be constantly effective. So studies have looked at the failure rates of different positions for needle decompression, but they found that that spot had a 40% failure rate. If you shift it to where you do a chest tube, it drops to 30%, but if you actually move that anterior a little bit to right behind the pec, drops down to 13, which, if that's a protocol you guys are good with, awesome.
Our actual protocol says that's the preferred method.
How perfect. Staying up with the times. All right. Do you guys have privileges to do chest tubes?
No chest tubes.
Okay. A little morale boost here. They've done some studies on EMS placed chest tubes, and of the small studies that they've done, 90% success rate. So if you guys are trained to do it, you guys clearly have the capability to do it. So awesome. Coronary thrombosis, fancy word for heart attack. It is the most common cause of sudden cardiac arrest. It typically presents as VTAC and VFib, so yeah, you get to shock them. But big thing with that is you're not going to fix that in a truck. You're not going to fix that in the emergency department. That is a CAMS, and all your cardiologists like to harp on time is tissue. So get them to us quickly as we can. Interesting thing that they talked about over and over again was don't stop CPR to get an EKG. When you got a normal STEMI patient, it's nice to know where the infarction probably is. But these people, their whole heart is, has less perfusion. So one, it's less likely to be, definitive. And then also you're stopping CPR, which we talked about already. So get them to cath lab, let the cardio gods do what they do best. Pulmonary thrombosis, it's a PE. Big thing again, get them to us. I don't know if you guys heparinize people on the way. Yeah, thought not. But so just get them to us. Big thing, you might see a low end tidal even if you're doing good CPR. So again, I'm talking about end tidal. We haven't talked about it, so let's talk about it a little bit. End tidal, it's how you measure the amount of carbon dioxide that's being exhaled. In a normal person, it's 35 to 45, and this is what it looks like with inspiration and expiration. If your waveform is flat, no air is moving. So again, check your circuit, make sure that everything's hooked up right, and make sure that you don't have any foreign body obstruction, anything like that. If you're doing good CPR, you are pushing enough blood to go to the lungs and therefore have some gas exchange. So if your end tidal is above 15, it means you're doing good CPR. Obviously, higher is better, and it's actually been correlated. A higher baseline end tidal is associated with higher chance of ROSC. So speaking of, if you get a huge spike in your end tidal and you didn't do anything like needle decompression or anything like that, that would explain it. That is your first clinical sign of ROSC. So great. If your end tidal is under 10, could be pulmonary embolism like we talked about. If you've been coding them for a good while, it does show that you're probably not going to get them back. Point of care labs. Everybody's got glucose now, and that's not going to fix code, but if it's low, give them sugar. If it's high, maybe think DKA. They've talked about some crews having hemoglobin hematocrit. I feel like if you think they need a transfusion, it's probably because you can visibly tell. But some places have it. They've also been trialing point-of-care ketones, which is actually pretty cool. The American Diabetes Association actually has supported the idea of checking a ketone level in EMS patients with a blood sugar over 250. So it might clue you into the fact that they have DKA, which might be able to start some interventions a little earlier. I think blood gas is a pretty cool idea. They've had some studies of EMS crews having a blood gas. Might be able, if you check a quick pH, might be able to tell you how long they've been down. None of those baselines have been established yet, but it's a pretty cool area of study for the future. Okay, you got them back. Now what do? Get them pretty optimized as well as you can on the way. If they're volume depleted, give them more volume, whatever form that may be. If you're using pressors, try and keep a MAP above 65, at 65 or above if you can. Avoid hyperoxygenating your patient. Has been shown to possibly cause reperfusion injury. Again, I'm not sure about the short time frame from you guys to us, but it has been shown in the hospital. So if you have a long transport, try not to keep them at 100% the entire way. Shoot for mid to high 90s if you can. And then start working on your H's and T's. Again, probably won't figure that out on the way here, but speaking of the numbers, it's probably a heart attack. Weird little bunny trail. The internal medicine and ICU folks have been talking about therapeutic hypothermia. They actually do use it in the hospital after a code. Has been shown to improve the neurological outcome. They did trial it in pre-hospital post-code patients. So far, it hasn't shown any benefits, but I think it's pretty cool that they're even thinking about it. When do you stop? So how the American Heart Association defines futility is persistent asystole with no identifiable cause, with no ROSC after 20 to 30 minutes of good ACLS, CPR, what have you. Means if they have PEA, if they have VTAC, they have VFib, you keep going. They didn't give us any guidelines of what a proper workup is to identify cause, so there's a little latitude there. And if they have an end tidal under 10 after 20 minutes, like we talked about, does show that it's most likely futile. Talking about some of the kind of special cases here, if they got a DNR, don't code them. If they got a DNI, I'm sure they're pretty good with you guys if you code somebody and then they find a DNR. But power of attorney, next of kin. In the hospital, they have the authority to decide withdrawal of care. I'm not sure how that works legally with you guys as far as calling it in the field, but I do know typically you guys have authority in certain cases, whether they've, it's a wellness check and they've melted into the couch, or if it's an obvious like decapitation or something like that. So all in all, talked about some of the statistics about cardiac arrest, especially the pre-hospital side. And even with all the best tools we have, it's pretty rough. So I'm sure you guys don't already know to not beat yourself up if you never get them back. Most common cause is a heart attack. So again, rush them to us so we can try and fix that. Covered our BLS and ACLS a little bit. Stole Dr. Ahmed's thunder with H's and T's. Talked about some of the cool diagnostic tools and upcoming possible treatments for cardiac arrest. Some of the literature that we've been going on. Some of the special cases. One other thing I forgot to talk about, I think it was in the slide, was kids. I know usually we code kids longer than we typically would if they're an adult. It's because they're kids. We do more heroic measures. But that's it. These are my references. And I'll take any questions you got.
If they have questions, they can email Jeff or Connor.
Cool.
So they have all left because the live stream, they give them the circle of death more or less.
Yeah.
Even though that's weird, it just now popped up on my computer to that screen.
All right.
Which is really weird. So I don't know what's going on with it, but it'll get fully uploaded here later. And so they can ask questions here, which is great because a lot of that information is stuff that we teach in ACLS. We talk about that in every ACLS class. So good info and
Nice.
good refresh as well. There's a few extra things in there.
Do you guys have end title on your?
We use it on every cardiac arrest
Nice.
patient.
Everyone.
Is it
We
It took a
really-
while to get that in the department.
Huh?
It took a while to get that in the department, but
Yeah, we use it on every patient.